Hello, everybody, and welcome to a webinar with myself and Dr. Adam Klotzek. Dr. Klotzek, thank you so much for joining us today and doing this. This would be great. I'm looking forward to learning from you.
No, thank you for having me and allowing me to just share some really, really good information.
All
Looking
right, so
forward
today
to
we're
it.
going to be learning about transcutaneous or transdermal pulsed radio frequency, because this is what the StimPod NMS 460 emits. So this is the device that I've become absolutely in love with because of the results and clinical outcomes you can get. But I think not enough people really know enough about it, and let alone even less people understand the science of it. Most clinicians have not leveraged pulse radio frequency, let
I would
alone know
agree.
the science. So you're gonna teach them about that. First, let me do a little bio on you, if I could brag on you for a moment here. Dr. Klotzek, DC, DAC, and B. He holds a doctorate in chiropractic degree from Logan University, along with his diplomate status in neurology. He's an accomplished worldwide lecturer in the field of neurology and neurological treatment, delivering over 700 presentations, totaling over 11,000 hours on various topics in neurology. He has over 25 years of clinical experience, has attended over 12,000 patients, treating them for a multitude of neurological and non-neurological conditions, including but not limited to things like concussion, vestibular disorders, chronic and acute pain conditions, dizziness, headaches, autism spectrum disorders, scoliosis, sports-related injuries. He also has special interest in developing novel treatment applications, the effects of joint misalignments on brain function, and he's authored a number of published research papers, including one that you just did in the last year, which got a lot of
Yeah.
attention, right?
Yeah, I was pretty happy to get
Yeah,
that one done
that
on the
was that
effects
was
of, yeah, the effects of adjustments on brain function, looking at eye movements and all that cool stuff.
yeah.
Well, it
I
was
gotta say,
good.
very, very nerdy, but right up my
Yeah, it was
alley,
very nerdy. I'm kind of
my
nerdy guy
type of
sometimes.
nerdiness. So, Dr. Klotzek, here's the way this is going to work.
Okay.
I'm going to mute my microphone and turn my camera off, and I'm going to let you present, and I'll be back at the end if anybody has any follow-up questions and to share with everybody a little bit of exciting news. So, I'm going to get off the stage if that works for you.
Yeah, that works for me.
All right. Have a
We'll
great
get started.
presentation, Dr. Klotzek.
All right. Thank you very much, Dr. Garcia, for the very kind introduction. All those numbers just mean that I'm just getting older as the days go by. So pay no attention to that stuff. So I'm going to talk to you guys about the science of transdermal pulse radio frequency. I came across this technology probably about, I'd say almost a year and a half, maybe 2 years ago. And I usually don't get excited about technologies because, they either come and go and a lot of technologies make a lot of claims that, end up being not so great in the end. But this one really caught my eye and my attention. And so I just want to take a little bit of time and just give you some background information as to why I feel, or my opinion as to why this technology is something that I think clinicians treating chronic pain or neuropathies or neuropathic pain may want to consider using in their own practice. And we'll kind of go from there. So, the first thing I want to address is really what is the problem in what makes neuropathy, neuropathic pain, chronic pain so difficult to treat. I mean, it's chronic for a reason, right? I mean, if everybody had the answer, chronic pain wouldn't exist. So either A, we don't have the answer, or B, we don't have the technology, or maybe both to treat it appropriately. So, what I'd like to start off with is really just addressing some of the mechanisms that produce chronic pain and then kind of loop that into why pulse radio frequency technology is something that you may want to consider using in practice as an adjunct or an extra tool in your practice to treat some of your patients who have some of these conditions involving chronic pain. So basically, we'll start off with this. The first problem with people who have chronic pain is that they have dysfunction of an area of the brain called the motor cortex. And we often find that people with chronic pain have movement abnormalities, suggesting that this area of the brain's probably not working so good. We also know that reduced output of M1, which is just the motor cortex, is observed in acute and chronic muscle pain patients. M1 structural, organizational, and functional changes appear to be present when pain becomes chronic in people. And there's also been a lot of reports with regards to associations between the severity of pain that people have and the degree of the actual movement dysfunction that they have. Now, this is going to become more apparent later on in the presentation when it comes to how dysfunction of the motor cortex actually promotes the transference between acute and chronic pain and actually maintains chronic pain. There's other individuals who are looking at the motor cortex, such as psychiatrists, and doing transmagnetic brain stimulation. That's starting to become popular in treating individuals with chronic pain, but it all revolves around dealing with some of the issues that are occurring in this part of the brain. So without further ado, we'll move on to problem number two in people who have chronic pain. And that is the whole process of pain sensitization. Now, pain sensitization is very well known. It's been around for a long time. A lot of us might pay credence to it. And I think we need to understand it a little bit better uh, to be more successful in the treatment of our patients with chronic pain. But it really revolves around two mechanisms. The first one is what happens in the periphery. So this is in the actual tissue, the muscles, connective tissue, etc. And what you have here is all these inflammatory mediators promote increased activation of pain fibers. And they also cause structural changes in the pain fibers themselves, such that the pain fibers become more sensitive to the actual presence of these inflammatory mediators. So that just increases their sensitivity, increases their activation. And at times, this can get so bad for people that, for instance, after an acute injury, they have this, flood of inflammatory mediators, and then the tissue heals, the pain fibers have become sensitized, and even though the inflammation returns to what was previously there before the injury, because of the sensitization and the structural changes that have occurred in the actual pain nerves, they still experience pain for the amount of inflammatory mediators that are normally present in tissue. Now, this is emphasized or made worse by what happens centrally. So, what's going to happen centrally, and this happens in the spinal cord and in the brain, you have the same thing happening. You get an upregulation, you get a reinforcement of pain fibers within the actual spinal cord themselves. You see structural changes happening to the actual ion channels. You see an upregulation. So everything just becomes heightened in regards to its ability to transmit pain. And that obviously is not a good thing for people. And in this instance, translates to people experiencing chronic pain. Now, the outcome of pain sensitization is ultimately three things. You're going to have increased pain, nerve excitability, period. You're going to have increased spontaneous pain with regards to nerve activity. And you're going to also see the expansion of receptive fields. So the area that you're going to experience the pain in expands. Now, this happens due to changes within the spinal cord, but also within the brain itself. And I'll just point you to this little diagram right here. So this is basically a little diagram that shows the pain nerve activity, pre-sensitization, and post-sensitization. So you see the amount of stimulus pretty well remains the same, but the degree of output of the pain system increases in situations of sensitization. So the other problem happens with regards to an area that is kind of misunderstood for a lot of people, because we see that high threshold mechanoreceptors also become sensitized. And what I mean by the fact that this is sometimes confusing is because in the world of pain, when you talk about mechanoreceptors, most people think of mechanoreceptors as the good guys, right? That we want to stimulate mechanoreceptors because we want to inhibit pain. And this has to do with, research that was done by Melzack and Wall with regards to their theory with regards to pain modulation, the gate theory of pain modulation. It's kind of been instilled in the chiropractic world and orthopedic world for many, many, many years. You stimulate large diameter nerve endings, mechanoreceptors, and this causes pain inhibition at the cord and other areas throughout the CNS. Well, these mechanoreceptors are different because these mechanoreceptors only activate under higher degrees of pressure. And when they activate, they actually activate pain fibers that are going to transmit pain to the spinal cord into the brain. Now, these mechanoreceptors can get sensitized. So, what that means is that they require less pressure, less mechanical force in order to fire and transmit pain signals to the brain. How that translates in real life, it's real simple. Normal movement that activates pressure sensors and tension sensors within tissue now can become painful because we're activating these high threshold mechanoreceptors. So that's a big problem that many people with chronic pain or neuropathic pain have is that movement irritates them. They just can't move. All your nerve stretches that you do as orthopedic and neurological tests become positive. You get these neuropathic pains shooting into arms and legs whenever you apply tension onto the nerve. They're allodinic, etc. And it becomes very difficult to treat these people because, from my standpoint as a chiropractor, my main tool that I utilize, the adjustment, involves movement. And sometimes when you adjust these people who are in chronic pain, it hurts them. And some people may respond, other people, they won't respond. It just keeps getting worse and worse and worse until they basically fall off as patients. So we're going to come up with a solution for that so we don't lose those patients in our offices. Problem number four is that you get rewiring within the actual dorsal horn of your spinal cord. And the two big things that happen in the cord in people who have chronic pain is the following: is that pain fibers migrate to make connections on second order neurons that are projecting pain to the brain. So normally speaking, in a cord, if you look at the segregations, you look at your mechanoreceptors, your large diameter nerve endings, they're going to come in there and they're going to pretty well make connections into laminas 2 and 3. Your pain nerves are going to come in and make connections on projection neurons. That's what PN stands for, in laminas 1 and 2 primarily. And that's normal. They stay separate. Now, in people with neuropathic pain, all bets are off. Things change. And what changes is that these um, pain fibers begin to migrate and make connections onto the second order neurons that were basically now transmitting pain. And this becomes problematic, as you can see, that every time you move and you stimulate touch receptors, say you're doing like massage or myofascial therapy on someone or stretching or something like that, now all of a sudden that becomes painful because these nerve endings now are making connections onto these second order pain neurons. And the last thing that happens is that you basically lose the inhibitory neurons within the spinal cord that block these pain signals. So you got a lot of stuff going on that is happening in people who suffer from neuropathic pain, suffer from chronic pain, reflex sympathetic dystrophies, etc., that make it difficult to use mechanical methods such as adjusting, such as myofascial work, stretches, exercise to help these people. So the next thing then becomes, well, what is the solution? And the solution, in part, lies in this new technology of the use of transdermal pulse radiofrequency, along with interrupted DC galvanic, which is a combination of what the StimBod provides clinicians with. So, what we're going to do is we're going to start off by talking about some of the old technology, and then we'll talk about the new technology, the old being the DC galvanic, which has been around for a long, long, long time. And the newer technology is the pulse radio frequency. So let's start off with the older technology. So DC galvanic has been around for years and years and years. It's been known as a nerve stimulating technology. It uses a low frequency, 20 to 60 hertz pulse or current pulse. It's a negative current pulse, which I'll explain to you in just a second. And it's used to basically stimulate nerves. So if you think about it, it's being used in a lot of different applications today. Your pacemakers use galvanic, your spinal cord stimulators use galvanic. Anything that, if you want to use a low frequency electrical current to stimulate a nerve, you're going to use a galvanic type of stimulation. So, how does it work? Well, basically, it works by doing the following. There's one part of the galvanic current that involves the use of the cathode. So there's a cathode and an anode. The cathode is negatively charged and the anode is positively charged. So when you place the cathode, in this case, if you're using the stim pod, you're going to use the probe and you're going to place it over a nerve. Okay. And when you stimulate, that cathode creates a negative environment right over the probe. And that negative environment attracts positive ions to it. And what it does is it causes the extracellular fluid to become negative, and then, in respect to that, the intracellular fluid of a cell or a neuron becomes positive, which equals depolarization. So, normally speaking, what tends to happen is that you tend to have sodium come into a cell to make the inside part of your cell positive to depolarize a nerve. Well, you can make the inside of the cell positive relative to the outside if you also make the outside more negative. So it's just a different way of stimulating a nerve, and it does so by doing it by removing these positive ions by having them attracted to an electrode, which happens to be the cathode, etc. And that produces this cathodal current, and that's what stimulates the actual nerve itself. So, why do we want to stimulate the nerve? Well, there are benefits to stimulating the nerve, which I'll get to in just a moment. But before we do that, I want to also address the fact that when you stimulate a nerve artificially, it's different than stimulating it centrally or normally. Okay, that you would do, like if you're going to create a movement or if you have a sensory stimulus or something like that. When you do it using an electrical current, the nerve fiber recruitment is different. So normally when you stimulate a nerve or a set of nerves, you're going to recruit from smallest to largest. If you use a galvanic type of stim, you're going to recruit from largest to smallest. And this is really important because the largest axons that we have in the periphery are your motor neurons as well as your sensory neurons that supply muscle spindles. So your group 1As and group 2s and your large diameter axons that are supplying mechanoreceptors, your A beta types of fibers. So this is really, really good because the large diameter, the skew of these large axon stimulations over smaller axons, which are associated with pain fibers, is part of the process that allows to create the pain inhibitory effect of DC galvanic. Now, the other part of DC galvanic is that it causes pain inhibition. And it does so by, again, as I said earlier, stimulating preferentially your large diameter axons, your A beta fibers, which, if you again recall Melzack and Wall and their gate theory of pain, just blocks pain signals at the cord. And then it also stimulates A gamma fibers, which then stimulates the release of enkephalons and beta endorphins, which also inhibit pain. Now you also have another effect, which is a central pain modulatory circuit that occurs centrally. So the activation of large diameter nerve endings in the periphery is going to stimulate your sensory cortex, your motor cortex, which we're going to get to, as we mentioned before, is very important because it's a problem in people with chronic pain. The anterior cingulate, with the insular cortex, all the emotional stuff that happens with pain, and all these areas become dysfunctional in chronic pain. So the use of this is a way to stimulate these areas. And one of the core theories or core philosophies in neurology is that neuronal health and stability can be promoted by stimulating the nerve. Obviously, you want to supply oxygen and proper nutrition to it, but simply stimulating a nerve can promote a better, healthy nerve and can also promote healing and other things to occur. Now, the effects are going to occur both in an orthodromic and antidromic way. So remember the whole thing, towards the cord and away from the cord. So orthodromic means away from the actual cord or where the cell body is, and antidromic means towards it. So if we look at just stimulating a nerve, so again, we're still on the old technology, but it's an important technology still, that the stimulation of the nerve in an orthodromic sense has all these great, great consequences that help the axon regenerate, especially people with obviously neuropathy, whether it's diabetic or compressive, and in neuropathic pain. People with neuropathic pain have damaged axonal sheaths, etc., which is part of the issue why they have neuropathic pain. So that's a positive. Centrally, the antidromic effects I already talked about with regards to changes within the actual cord to promote pain inhibition, and then the activation of brain centers to act to further promote pain inhibition. Now, when you're using a stim pod, one of the things that's talked about a lot is this twitch response. And the twitch response for a user signals that they're on the actual nerve that they want to stimulate. So, is the twitch response important? And I'm going to make an argument for the fact that it actually is important because what the twitch response does, and I'll just show you what this video looks like. So you can see that twitch response. So we know we're on the nerve, we know we're stimulating the nerve. And by stimulating the nerve, we're activating spindle afferents, we're activating ventral horn cells within the cord, we're activating the sensory cortex, and we're also activating the motor cortex. Now, the relationship here with regards to pain modulation is as follows. When you stimulate the motor cortex, you activate descending pain inhibitory systems from the brain, particularly the periaqueductal gray area, as well as various thalamic areas that are also responsible for pain inhibition. So, what a beautiful thing, right? You're activating the nerve, creating a twitch response, and that twitch response activates centers within the brain that promote pain inhibition. But you're doing this in an environment that's not painful for the patient, which means that you're not activating the pain system that has already become sensitized in regards to people who have chronic pain. So if you have a person with a neuropathic pain and you can't move them, where do you start? You start by doing something to stimulate the nerve in order to create pain inhibition by specifically activating large diameter nerve fibers and creating the central changes that activate the motor cortex and so on to produce pain inhibition. Now, that's the old technology. Now, what StimPod is really, really cool for is that it's combined that old technology with a newer technology that I find extremely fascinating, and I want to share with you because I think it's great with regards to its ability to further pain inhibition in the treatment of these neuropathic pain types of syndromes. So, to give you some context, let's go back a little bit and kind of talk about where this all came from in the first place. You know, the radio frequencies and pulse radio frequencies, etc. Well, basically, it started off back in 1974 by an investigator by the name of Shealy. And this investigator discovered that exposing nerves to a constant radio frequency wave, not a pulse one, but a constant one, around the 500 kilohertz range promoted heat-induced thermocoagulation of C fibers and A delta fibers. And that was a great discovery. And it led to a whole industry that basically uses radio frequency ablation, and you probably heard of it, for various neuropathic pain syndromes. Now, that's ablation and that's causing damage, which is a lot different than the pulse radio frequency that we'll be talking about. Later in the 80s, though, after this initial discovery, there was conversations going around as to how this not pulse but radio frequency actually worked in ablating the nerve and the results that it got. And researchers observed that radio frequency lesions could also be effective if they were applied to nerves peripheral to the nociceptive focus. So let's say you had a focus at, I don't know, maybe C1 or something like that, or C2, and you had like a suboccipital type of neuralgia. Well, if you ablated nerves at C3 and C4, it also reduced the pain that a person was experiencing due to the irritation or the neuropathic pain syndrome at C1 or C2. So that was interesting. They were like, why is that happening? In 1997, another researcher proposed that the use of pulse radio frequency as an alternative method to treat several painful disorders. And what this does, the pulse radio frequency does, it exposes nerve tissue to, the same 500 kilohertz radio frequency wave, but it's going to be pulsed at 20 millisecond durations for about 2 to 8 minutes. And it basically warms the nerve up, but only warms it up not to the point that it's going to damage the nerve, right? And they started noticing some great results with this. And then basically, pulse radio frequency really became mainstream back in 2005 when Texaria found that intra-articular application of pulse radio frequencies could relieve pain. So they would go in here and they'd apply these pulse radio frequency treatments within the actual knee joint, within the facet joint, without damaging nerves and actually getting great results. So now the question becomes, well, how the heck does it work, right? What does it do? Well, this is a pretty complex representation of a summary of the things that pulse radio frequency does. I am by no means a medicine, pharmaceutical doctor, so I'm just going to kind of summarize some of these things for you. For those of you that want to go more into detail on these things, you can. The green arrows represent upregulation. The red arrows represent downregulation. So what happens with pulse radio frequency is that you upregulate M2 macrophages, fibroblasts, collagen, and you also increase wound healing. Okay, that's been proven and is very, very well known. Now, this upregulation just doesn't occur at the site of the stimulation. So when you put the stim pod, the probe on the nerve, within that probe, even though you're getting the DC galvanic, the twitch response, etc., there's also it's also emitting a radio frequency pulse at the same time. And that's creating these types of changes along with the galvanic part. Um, we also see the upregulation of CFOS, so immediate early gene responses. You see mitochondrial changes. The general notion is that mitochondria become energized, they become more active. That's a very good thing because individuals with neuropathy, chronic neuropathies, their mitochondria become depleted. And that's one of the mechanisms of why these nerves can't heal because they don't have the mitochondrial substrate in order to energize the actual nerve itself to produce the things it needs to produce to basically heal. So basically, in essence, you have decreased nociceptive signaling with pulse radio frequency, and you have improved synaptic function and improved nerve injury repair. That is just not localized to the point of stimulation, it spreads out over a distance, which I found very, very fascinating. So let's look at just some axon tissue organelle effects of pulse radio frequency. Axon and myelin. It reverses neurodegenerative changes seen in neuropathic pain. It increases the number and diameter of axons. Now that's freaking cool. I mean, galvanic doesn't do that, but this does. And what a great thing because in neuropathy, that's one of the big problems. You lose your axons, you lose the number of them, and the ones that you have become smaller, become degenerated. And it also increases the myelin sheath thickness. And that's super important. I don't think I need to explain to you why. Most of you would obviously understand why that would be important. In these neuropathic pain syndromes, one of the biggest issue is, amongst many others, is that the myelin itself becomes thinned out. And then you start to get these ectopic depolarizations where you're having the axon being stimulated at points where it shouldn't be stimulated. And that's why you get these spontaneous pains and things along those lines. Organelle changes. Now, this is interesting. The organelle changes are different depending on the diameter of the axon that the pulse radio frequency is affecting. So the changes I'm going to show you here are specific to C fibers. Okay, and what you tend to see is that you see mitochondrial swelling, you see dysfunction in mitochondrial membranes, and increased microfilament and microtubule disruption only in C fibers, which is exactly what you want. We see the opposite effect in the larger diameter axons, such as your alpha motor neurons, such as your A betas, group 1A and group 2s. So just think about this. So you got a person who has chronic pain and they have overactivity of their pain fibers. They're sensitized, that system has been upregulated. You can't utilize movement in order to help the person because that movement itself also promotes the pain through changes within the dorsal horn. So you're kind of like between a rock and a hard place, right? Like, what do you do? Well, what you do is you can use this technology to stimulate the nerve. And this technology, the pulse radio frequency, will specifically downregulate your C fibers, which is what you want, and upregulate the large diameter nerve fibers, doing all the good stuff, all the stuff with pain inhibition, stimulating the motor cortex, pain inhibition, all in a state that they don't experience pain. So if you can do this for a person that can't move, anytime they move, that hurts, and you can do this and create an environment for them that they're not feeling pain, you're balancing on the right side. In other words, you're balancing the activation of all the endogenous inhibitory systems and you're upregulating that side of it. And that's what I find extremely fascinating and I think of extreme importance in the treatment of chronic pain. And when I was in practice, I wish I would have had this device. I mean, I could just think back many, many patients I could have used this on and probably achieved better outcomes. There's also neural connective tissue changes. increase in the number of macrophages, increase fibroblast activity, collagen. So you're getting the idea, right? And it improves wound healing in diabetic models. My gosh, that's a big issue for some of these real bad diabetics, where they get these ulcerations and all this other stuff. So just super, super cool stuff that can be achieved with pulse radio frequency. So here you have a device that combines old with new. It's like the special sauce. Um, it's like a Big Mac. What's the special sauce that they put on Big Mac? It's like the recipes locked up in a vault somewhere, or something like that. So this is the special sauce. So you're combining low frequency direct current with high frequency alternating current. Both of reduce inflammation. They do it very well. Both stimulate M2 macrophages. Okay, this is going to happen more locally. This is going to happen more broadly. Um, the pulse DC galvanic favors activation of large diameter nerve endings. The pulse radio frequency reduces C fiber and sympathetic nerve fiber activity, both which you want to happen in people with chronic pain. And the DC galvanic activates the motor cortex, activates central pain inhibitory circuits. Pulse radio frequency promotes axon regeneration, myelin production, and affects all surrounding tissue, just not the nerves themselves. Now, what can you use the device for? Well, you can use it for any type of chronic intractable pain, post-surgical pain, rehabilitative pain. And doctors that I've spoken to and other my colleagues are seeing great, great results with all these different types of disorders: neuralgias, trigeminal, diabetic neuropathies, radiculopathies, sciaticas, pretty well anything involving pain and nerves um, is game on for this type of technology. And again, from what I've seen, what I've heard, my own personal experiences with the device, it's the real deal. Um, it does what it says, and it does it really well. And I hope understanding why it does it is of benefit to people, and that's why I put this together for everybody, and hopefully it's of value. So just want to thank everybody for your time. Hope you enjoyed it and hope you learned some things. If you have any questions, you can always email me at DLX. I'm sorry, there's an error there. It should be dlxstrat@msn.com. One S, not two S's. Or if you need more information, you can also email info@algemed.com. And then I'll let
Dr.
Dr.
Klotzek,
Garcia.
I'm here. I'm here.
All
Perfect.
right.
Thank you so much. And thank you for navigating it by covering both sides of what the NMS 460 is actually transmitting. Because I think it confuses people as
Yeah.
it when they don't realize that it's doing two things, but they all have their purpose, right?
Yes.
Like it's like people hear about the galvanic, and I go, hey, it's for the nerve locating, so you know where you are. But there's also some positives to the galvanic waveform, and we shouldn't throw that out. But and I love the way you say it's the secret sauce. Both those things together give you it's like a 1 + 1 = 4 type of scenario, right? It's more powerful than them individually. But the
Yeah.
pulse
And
radio
as far as,
frequency is
yeah.
undoubtedly the magic sauce that gives people such amazing outcomes.
And as far as I know, I think this is the only device that has done this. I think it's a brilliant idea.
Yeah. When I
Uh,
talk to clinicians about it, I tell them, I go, the odds of you having used pulse radio frequency before is very small. And when they finally get it, they are very, very surprised about how incredible it is. Like they just go, they become obsessed with
Totally
it. They
agree.
become obsessed with it because it is one of those things that in 3, 4 minutes of treating a patient, you literally have a better outcome. It is that quick. I know I have some acupuncturist colleagues that are doing 30-second stimulations and getting incredible outcomes.
Interesting.
So
Interesting.
Dr. Klotzek, so just want to thank you so much for your time
No,
today.
no, I appreciate
Really
it. Thank
appreciate
you.
it.